Hey guys, it's Dr. Steph here. I'm one of the lecturers for the Personal Finance curriculum at U of T, and today we're going to be talking about family medicine billing for family medicine residents in Ontario. So I've given this talk at several schools, and every time I've given this talk we could never finish the slide deck on time. So I just finished working this afternoon, and I'm going to be recording this lecture for you guys today. So let's begin. So just a quick intro about me. So as I mentioned before, I talk about personal finance for the med students and the residents at U of T. I'm also on the financial aid committee. I blog about personal finance on Instagram at Breaking Bad Debt. And I also do hospital-based addictions medicine and community medicine as my day job. So what are we going to talk about today? So I wanted to explain to you why is it important to learn billing in residency. What are 3 billing habits to start in residency? Give you some priority billing resources, talk about EMR systems, and the high yield codes, as well as practice questions at the end. So just so you're aware, I don't have any conflicts of interest to disclose, and everything's for education purposes. As well, the OMA and the CMA has made every effort to ensure that the examples in the practice billing section are representative of best practice billing. So why is it important to learn billing in residency? Well, during my lecture, I usually do these audience polls for the students, and I try to ask students, do your preceptors show you how to bill after you see patients in clinic? Or, do they show you how they get paid in that particular clinic setting? And this is what the students said. So this is a poll of about 177 students, R2s across U of T, U Ottawa, and Queen's Family Med. And the majority of students actually don't have preceptors who show them how to bill. So the next question I asked my students is, are you comfortable asking your preceptors about what billing codes they use or, how much they might make on an average clinic day? And this is what the students said. So a majority of people are pretty comfortable asking their preceptors. However, there's still quite a lot of students, about 76 of them, who aren't really comfortable. And that's totally understandable. Sometimes you might not be that comfortable asking your preceptor. And so in terms of the other section, people who replied other have said that they might be comfortable asking about the billing codes, but they may not necessarily be comfortable asking how much can someone expect to make in an average clinic day doing what you do. I also wanted to ask a lot of my students, how prepared are you feeling when it comes to starting practice? And in terms of the results, a lot of students are not prepared at all, or they might know some basics about billing, but not fully ready to be independent. And I actually found that these results are kind of surprising, but also not surprising, because a lot of these students were polled in kind of their last quarter of their final year of residency, so the year when they're going to become a staff physician in a few months. And similar to a lot of these students, for myself, when I was in their position, I was also probably in these categories as well, not prepared at all. And so, I feel like as preceptors or as lecturers for these students, we have to try to do better in terms of providing these resources out there for students to feel competent and ready when it comes to practice management when they graduate residency. And this was kind of just a curiosity poll. I just wanted to see what students thought family doctors made per hour. And about 181 students answered, and for the majority of them, they said about $100 to $150 an hour. And I don't think they're wrong, but there's another learning point I wanted to make with this question, which I'll talk about in the upcoming slides. So when I graduated residency, it felt like being thrown into the deep end. And there's a lot of things that I didn't know when it comes to practice management. And so when I finished clinic doing all of the clinical stuff, I spent hours after clinic trying to figure things out. And so one of the things I didn't know is what is covered by OHIP and what is not covered by OHIP billing. So what you can bill OHIP for is any time spent in the patient's presence. So for example, traveling to patients' homes, doing hospital call, as well as the cost of supplies. So things like tray fees, syringes. The only exception to that is if you're in like a FIT academic center, for instance, where the government provides you with funding to cover those, and it's not coming out of your OHIP, your overhead, then it's not something you can bill OHIP for. And what you can't bill OHIP for is, time spent charting, time spent billing, time spent reviewing a patient's file before seeing them, which I did a lot as a resident, time spent doing admin work, and time spent trying to figure out the EMR system. So there's all of these things that I spent like 2 to 3 hours for. I was working until 9 p.m. every day, not because clinic finished at 9 p.m. It's because I was spending all this time doing unpaid work like this kind of stuff here. So that's why it's important for us to kind of talk about this practice management stuff, because a lot of this work is just unpaid, and I spent a lot of time as a new grad doing this kind of stuff. So just to kind of emphasize a bit more and kind of give it a case example. So for example, let's say if you're making a gross income about 240 grand as a average family doctor in Ontario, and let's say you work 52 weeks a year. You don't take a vacation because it's the pandemic and we can't do that. And so your daily work income comes out to be about $1,000 a day, which is your typical locum rate if you work 8 hours a day. You take away tax, which is about $94K or $49 per hour. And the after-tax hourly value of your time is about $76 per hour after tax. However, let's say you spend a lot of time trying to do all of that unpaid work that I talked about in the last slide. You spend 2 to 3 hours after work just charting, billing, and doing the admin stuff like I did. So that comes out to be about $42 after tax. And this doesn't even include overhead deduction. And so I wanted to give this particular concrete example because, when we graduate, we spend a lot of time trying to figure this out because we never really learned it in residency. But the second point I wanted to make about this is a lot of residents I heard will say, oh, I can't wait to make staff salary when I graduate. And so in their minds, they think that they're making $100 to $150 an hour, but in actuality, they're making $42 per hour. And so there's a big discrepancy there. And when we talk about lifestyle inflation, a lot of residents, when they graduate, they'll be like, okay, I'm going to start spending more. I'm going to upgrade my life. However, there's a reason why people say live like a resident, even when you're a staff for the first couple of years. You don't want to end up having that like lifestyle elevation. And you also want to make sure that you still have enough at the end of the day to pay down your enormous student debt. So I want to talk about some 3 habits to do as a resident to prepare yourself to learn billing as a staff, especially for a lot of those residents who said that their staff physician didn't really teach them how to bill after clinic, and nor are they comfortable to ask, how can we kind of get into the billing habits when we have those kind of preceptors? So my first tip to you is ask your preceptors, is there anything you need me to include in my note for billing purposes? I think that's a better way of asking your preceptor to teach you how to bill instead of directly asking them. And staff physicians like it when residents make their life easier, so anything that makes it more efficient for them to bill. And a lot of residents, they may not be comfortable asking their preceptor about billing, so this is kind of an indirect way to go about doing it. So some staff will say, oh, can you remember to collect the patient stickers of the patients you've seen for me? And I've seen a lot of EMRs docs will do this. And the reason why they ask this is because the patient's OHIP number is what they need to bill. Some staff will say, can you write down the start and end times you spent with that patient? And what this should teach you indirectly is there are some billing codes that the staff will be billing and that are time-based. So the staff will only get paid if you spent, for example, at least 20 minutes with the patient when it comes to that billing code. The second tip is get into the habit of signing your notes like this. So most residents, including myself, will sign their note as their name, PGY2 reviewed with doctor staff. But what I started doing when I realized my staff physician or preceptor didn't really start teaching me about billing is I wrote down my signature, but I also wrote down the time, and I wrote down what billing codes I think this particular case I would have billed. And so putting the time is important because, it's important that you know how much time you spent with the patient when it comes to improving your office efficiency. And it also helps if in case your staff gets audited when it covers the time-based billing codes. This code right here is known as the billing code. So for example, the K005 code is a mental health care code, and this is a diagnostic code for depression. And look, it's okay if you get both these codes wrong. Putting it there just helps your staff's billing easier in case you do get it right. And if you get it wrong, it gives the staff an opportunity to correct you, and then you learn from your mistakes. And finally, it's important to start compiling templates because charting takes up a lot of time and you don't get paid for charting. So you want to start compiling templates for the mental status exam, for the GAD-7 PHQ-9, as well as common management plans, like things where the management plan doesn't usually change from patient to patient, or it changes very little. And so for most of my assignments and plans, they tend to be copy and paste, and it helps me save a lot of time. I started compiling a lot of these templates as a resident because often in the residency EMR system, there will already be like existing templates, like for example, the mental status exam template. So start trying to copy them onto like a notepad or onto a Google Doc, just so that you can have them available once you go out on your own. The other bonus tip I wanted to give is when it comes to you being audited for your billing, or if you ever get a patient complaint or anything like that, and they have to go back to your documentation, you have to remember your note is the only record available in that case. So it's really important to make sure that your note is complete so that if you ever do get audited, at least you have the record of everything. And not to mention, having the templates available kind of helps jog my memory for if ever I forget to counsel patients on red flags, for example, like when you should go to the eMERGE. Those are pretty important things you should be telling patients. So if you don't remember to do that, since you're busy in clinic, at least your template will remind you to do that. So a lot of residents will ask me, okay, what are some main billing resources? And it's really important to know where to look versus knowing the billing codes off the top of your memory. So, and the reason I say this is because, you know, as family medicine residents, we're only in residency for 2 years, and it's really hard to remember everything. Like we have so many exams, we have so much to know. So often with us, it's like if we don't know something, we go on up to date to check it, right? So it's more important to know where to look than to know the exact answer for everything. So what resources should be in your billing toolkit? So I'm going to provide you with some resources in the next slide, and I think as long as you memorize those resources and you know where to find them, you should be able to do 90% of your billing without any problem. The first resource is the section on general and family practice, and it looks like this. I put the link on the slide so you can refer to it, and I would bookmark this on your clinic computer so that you have it as reference. The second resource is the schedule of benefits, and I don't actually recommend you read the whole thing because this is like a very thick document. This is only used if you wanted some reference or clarification on a billing code. And I've also provided the link there that you can bookmark as well. The third resource is the OMA billing guide. And so they have several PDF documents on like specific types of billing and when to bill certain codes. I think this is a pretty good resource, but I would also use it in the same way as that previous resource with the schedule of benefits, just because it's a ton of information to read through. And if you're a visual learner like me, it's not necessarily ideal because it's just so much text to read. So it's kind of good just as like a reference if you're not sure about something. And one of the most important resources I find is the First 5 Years in Family Practice Facebook group. So this is the Ontario version, and this is the Canada version. And I really like this because not only can you put in like a patient case, anonymized of course, and have other colleagues who are older than you or have more experience than you comment on how they would bill in that particular case if you're not sure. But also, if you're not really sure how to manage a certain patient, you can also post on there and ask your senior colleagues what they would do. And I find that people have provided lots of really helpful info on this group. And don't forget, most people will work in a setting where there are other clinic physicians there. And sometimes people will have a billing manager or office manager in their clinic. And I find those are also additional people that can really help out as well. So the other thing I want to talk about is your EMR system, because this is another area that caused a lot of, it was really, really time consuming to figure out when I graduated as well. So when you start off locuming, you have to get used to many different EMR systems. Like obviously the first three, Accuro, OSCAR, and TELUS PSS, are pretty common ones that you might encounter in residency. As well, you might encounter, things like Epic, Meditech, or your hospital-specific EMR. But something I didn't realize when I started practicing is that if you're working in a hospital setting, hospital EMRs don't actually have billing software integrated into it, so you have to get your own. And so when I asked a poll of hundreds of physicians what they use, a lot of the times they use a lot of these independent billing softwares that they can use to bill if they're working in a hospital setting, for instance. And just for the conflict of interest reasons, I'm not going to endorse any of them. I just put all of them here. And a lot of them have like these free trial periods. So you can kind of trial several of them before you start paying the like monthly fee for them as well. So when you're billing on an EMR, you also have to learn kind of how to bill on an EMR system, right? So this is what a screenshot of my EMR might look like. And so what it would include is the patient's OHIP number. I've kind of just blocked them out for privacy reasons. You would put in your billing code in here as well. You include a diagnostic code, and this is kind of important for people in like certain practice models where there are bonuses, and more on that on the second part of this lecture. Or if you have a certain number of diagnoses in your roster, like schizophrenia or bipolar, that helps you get a bonus at the end of the year. So that's why we put in diagnostic codes. Quantity, so if you have time-based billing codes, and whether you submitted your billings or not, it's important. So here you can see I did not submit my billing. And it's important that you submit your billings by the monthly deadline, because your billings will be paid the next month. So there's a bit of a 1-month delay. And I've included this picture here, so it shows the cutoff times for when you should be submitting your billings, usually on the 18th or the 19th of every month, so that you can get paid the next month. And remember, you can't bill until you have a billing number. So we won't be covering that in this current slide, but I will refer you to this particular video. I've linked it down here. And in this video, it just kind of talks about the timeline that you should follow when you're about to graduate to residency, when you should start applying for CPSO, when you should apply for a CMPA, and like billing numbers, it's also another headache that you have to go through. So I kind of talked about some mistakes that I made that delayed my billing number and how you can prevent yourself from making those same mistakes as well. So yeah, basically when to do what, about your job search, and how to avoid getting your billing number delayed. So in this section, I want to talk a bit about some high yield billing codes. You guys might know already about these billing codes, but this might be a bit of a refresher for those who don't remember. So just before I begin, 3 golden rules of billing. Number 1, you always want to be honest about your billing. Obviously, you're costing taxpayers money, you're being paid by taxpayers money, you're being paid by the government, so you want to be really honest about what you're doing when it comes to billing. You want to document, because that is proof of your billing and why you billed the way you did. And finally, just always remember to ask if you're not sure. There are always other people out there, clinic managers, there's other physicians working with you who can teach you in 10 minutes what you should be billing instead of you trying to figure things out on your own for hours. So let's talk about the most commonly billed billing codes in family medicine. So your A001, that's basically anything less than 10 minutes, prescription refills, if you provide like a sick note or something, simple rash, things like that. Your A007 is anything 10 to 20 minutes long. So this is your most office visits, doing your history and your physical exam. And your A003 is basically like your med school history and physical, when you're examining 2 or more systems. And this you can only bill 1 time per patient per issue per year. Unless they come in with a separate issue, then you can bill it again. And one point I just wanted to make is regards to sick note, if you're just doing the assessment in order to write the sick note, but for the actual sick note itself, some clinics will actually charge the patient and ask the patient to pay. So that's going to be talked about in the second part of this lecture. And a K013 is your more than 20 minutes providing patient education at a pre-booked visit. Any sort of counseling, cholesterol counseling, weight counseling, etc. And just as a heads up, this document that I've taken the screenshot from, which is the SGFP document, that's from 2015. So a lot of these codes have actually gone up a bit since then. However, there hasn't been any updated version, and this is kind of like the best resource we have so far. So this is no longer $33. It might be like $36. This might be like $67. And then right now with the pandemic, there's a lot of telemedicine codes as well. So the 𝗧𝗲𝗂𝗧𝗀 is the telemedicine equivalent of an A001. 𝗧𝗲𝗂81 is the equivalent of an A007. And 𝗧𝗲𝗂82 is the equivalent of a counseling code. And I put in brackets the 87, 88, and 89 for patients who don't have OHIP. And you can be able to provide them telemedicine care. So you would build these codes as well. Okay, so let's focus on the different sections of the first page of the SGFP document. So the mental health code. The most common one we probably bill is the K005, which is any mental health concern that's more than 20 minutes. And it can be combined with an A007 if the patient comes in with like a rash and they also want to talk about their anxiety, for instance. And so just remember, for these mental health codes, you want to write down the start and the end time, because this is when the number of units we talked about comes into effect. So for example, if you saw a patient for 40 minutes, you actually wouldn't be able to bill 2 units of the K005. It's only after 46 minutes, then you can bill the K005. So you might as well like talk to the patient for 6 extra minutes if you want to bill 2 units of that billing code. And so I've included this chart here for reference so that you can refer back to it when you do become a staff yourself. Okay, so screening and preventative care codes. So, a lot of these codes in the brackets here are the ones that I use most often, and they're the most commonly used and can be combined with vaccine codes, pap smear codes, FIT codes, and you usually do these in one of your typical complete physical visits as well. The other thing I just wanted to point out is the K030, which is the diabetes counseling code and physical exam. So this is not a time-based code. It's for any time you do your, comprehensive diabetes counseling, your microfilament exam, and so on, right? So you can bill a maximum of 4 per year or every 3 months based on the screening guidelines. And once you bill, let's say you see the patient more than that, that unlocks another code, which is the Q040, if you're in like a enrollment, like a rostered patient model. And that's if you're billing more than 4 a year. Some of these codes, like the FIT, for example, will have a little box at the corner of the form to remind you of what to bill. So make sure you pay attention to those boxes. Okay. Vaccination codes are listed here, and these can be combined with any visit code as well. But just a heads up, the G700 is for if the patient solely comes in just to get their vaccine for something, then instead of billing like an A007 plus the vaccine code, you would bill a G700 if they're only here for the vaccine. And now, in the time of coronavirus, there's these additional coronavirus codes as well, so H409 and 410. And these are kind of billed on an hourly basis. So for example, if you're working in any sort of COVID clinic or COVID setting, vaccination setting, doing COVID swabs to test patients, these are what the hourly codes are. So it's not on a per patient, it's on a per hour basis. And you will need a site code to bill this. So the site code is usually provided if you're working as part of a hospital or a public health unit. Okay, procedure codes. So the procedure codes here, the most common ones I use are on this page. And the one thing to remember are these tray fees. If you're working in a community setting where your overhead goes to pay for the equipment of the office supplies, these tray fees help a lot to cover these costs that you pay out of overhead. And the other one I wanted to draw your attention to is the pap smear code. So the pap smear is a G365 with the tray fee. The one thing I wanted to bring your attention to are these caret symbols and the plus signs. And so I'll try to talk about that shortly as well. So one thing just to remember is in addition to the procedure codes, don't forget to bill for things like your urine dip or your pregnancy test. Those are all things that come out of your overhead if you're in a community setting. And so even though this is like very little, it's only $2, it helps pay for like the cost of your equipment. And just as a heads up, so I talked about these caret symbols and plus signs. They're kind of like a visual reminder. So whenever you see something with a plus sign next to it, it means that if the patient only comes in for like a flu shot, you can combine it with a G700. If they have a caret sign next to it, it means that you can add a tray fee to that. It's like a visual reminder. So for example, if someone comes in with a pulled elbow, it has the symbol next to it, that means you can add a tray fee. But allergy injection, you can't because it doesn't have that symbol next to it. The other thing is a lot of students will ask me what are the N's and what are the O's. The N's stands for FHN, F-H-N, or Family Health Network, and the O stands for FO, Family Health Org. And it just basically tells you what are considered in basket or out of basket for each type of billing code. So just remember, a lot of these procedures like vaccinations and urine dips and stuff, they can be done by nurses in your clinic. And so if your overhead covers nurses, then they can provide a lot of these services and help you save time as well. Okay, 𝗏𝗧 codes. So your P004 is just for your routine visit. Anytime someone comes in for a prenatal assessment, some doctors might bill it at their initial visit. Your P003 is usually when your pregnant patient comes in, they tell you they're pregnant, and you do that full physical exam on them, and you do that full history on them as well. The P005 is for filling out the antenatal form, which is that big, long form with all of those check mark boxes on them, and it takes a long time to fill, so you're getting paid for your time doing that. And after your patient gives birth in the hospital and they come back to your office for a postnatal visit, that's when you would bill a P008. And just don't forget, you can always add on the G005 pregnancy test with your visits as well. And as a reminder, you can't bill a P003 and a 4 together because it doesn't make sense to bill like a major and a minor prenatal assessment. But a lot of doctors in their first visit, they might bill like a major prenatal P003 with a P005, or they might bill a P004 and a P005 together. And the other 𝗏𝗧 code you might encounter is the STI codes. So if you have a patient who has tested positive for STIs, and you want to bring them in to let them know that they have chlamydia, for example, and you want to counsel them about, informing their partners and what the next step is, putting on a condom, like those kind of things. If you're spending 20 minutes counseling your STI patient, you can bill the K028 for that, if they have been diagnosed with an STI, that is. Okay, smoking cessation codes. So the E079 is a very common one that family doctors will bill. And just remember, this is billed by the patient's family doctor, not if you saw a patient in a walk-in clinic, not if you're an addictions clinic like me. I wouldn't bill this. I save it for that patient's family doctor to bill, just out of common courtesy. And this is for the first time when smoking cessation is discussed with a patient for the first time. Your K039 is for follow-ups. So you can bill it 2 additional times in 1 year. So this is specifically when you bring that patient in for a follow-up to talk about like, oh, how was your nicotine patch? Or are you interested in starting a nicotine patch, for example? And it can't be billed with another K code. And you can't bill it with like another, like an A007, unless the A007 is for like something else not related to smoking, like a rash or something, for example. And then at the last couple of pages, you'll notice these diagnostic codes. To be honest, there's so much things to memorize in family medicine. Don't memorize any of these, because often in your EMR system, when you type in the diagnosis, it'll auto-populate with the diagnostic code. Okay, so let's do a few practice cases just so that you guys can kind of get in the hang of things. And I'll show you the answer, but if you're not sure why the answer is the answer, just ask in the comments down below and I will reply you there. And it'll help other students understand why that's the answer as well. So just take out a pen and a paper, write down what you think the answer is, pause the video if you need more time. And the answer for this question, what would you bill for an assessment of a 32-year-old male with upper respiratory infection who requires a B12 shot as well, is B. And the reason for this being the answer is the A007 is they come in for the upper respiratory infection, and your G372 is your injection with visit, the $3.89. So this second case, what would you bill for a complete assessment of an 85-year-old with chest pain and a urine dip? So pause the video and write down the answer. And the answer is A. So you would do a general assessment, and it says with diagnosis other than 917. So that's basically your well adult exam, your complete physical. They chose A003, and they did a G010. And so I didn't make these questions. I think the OMA did, but a lot of students, when I do this in lecture, they will pick either like a K013, for example. But the reason why they picked the answer is A003 is because you're assessing more than one system, right? So when you have a patient with chest pain, you're assessing not only the cardiac system, but also the respiratory system or the GI system and so on. Okay, billing case number 3. What would you bill for a 40-minute appointment with an anxious patient who also wanted a pap smear? So pause the video, write your answer. And the answer is C. And the reason why is because it's an anxious patient, right? So you don't want to bill a K013, which is just general counseling. You want to do specifically mental health counseling. So K005 as well as a pap smear, which is G365. And don't forget what I mentioned about the plus sign. You can add on a tray fee as well. So E430, pap smear tray fee here. Okay, billing case number 4. What would you bill for a medication refill where you discussed a prescription over the phone? So the answer for this is C, a K080, because it's a telemedicine visit and it's less than 10 minutes. You just quickly refilled it. But if you talked about it for much longer, or you switched a refill and it took more than 10 minutes, then maybe you would bill a K081. So some residents have picked this D as the answer as well. Okay, longer case number 5. A 31-year-old female comes in with a pregnancy test which is positive. She is 6 weeks gestational age, and you interview and you ask her all of her antenatal risks. You educate her regarding the latest maternal testing options, and then you order her antenatal blood work. You decide to start her antenatal forms, and you measure her blood pressure and her weight. She then books for her full prenatal examination at 9 weeks. So pause the video, do your control find on your SGFP document to see what you think the answer would be. And the answer for this is D. So I've included the screenshots here just to kind of help you jog your visual memory like how I learn. And the reason why is you do a minor prenatal assessment here because you're going to do your full prenatal assessment, your major one, in 9 weeks. So that would be the P003 later. And you also filled in her antenatal forms. So that's why you bill a P005. And you also did a pregnancy test on her, which tested positive. So you bill a G005. Okay, so those are some of the examples. And there's going to be way more examples in the PGY2 billing lecture. So what I'll cover there is premiums, modifier, as well as bonuses, how to deal with billing rejections, WSIB, as well as uninsured billing, and the practice scenario. So really watch the PGY2 lectures I think I have like 20 different billing scenarios in there that we go through, and that is super high yield for you to learn billing. For your homework today, just watch this video before you move on to the PGY2 lecture. How do doctors get paid? Because in here I talk about the physician payment models, the FIGs, the FOs, the fee-for-service. I talk about, why would you want to work in a purely fee-for-service model? And what's the pay like working in this type of model? And I kind of compare the different models, the FO, FIGs, fee-for-service, and so on, and how much you might expect to earn in each type of practice model. So be sure to check that out. And if you have any questions, leave it in the comments, or you can reach out to me at Breaking Bad Debt on Instagram or on YouTube as well at Breaking Bad Debt. Just remember to like and subscribe to be notified of future lecture recordings. And if you want to collaborate with me on, if you're like an instructor and you want to collaborate with me on any sort of billing lecture for your own province, feel free to reach out. I'm happy to share my slide templates and so on, and I'm happy to work with you on that as well.